In this video, I'm going to show you how to critique and interpret the quality of foot x-rays using the PACEMAN image evaluation criteria. I'm going to take you through 5 different examples, so you should be able to know what to look for and how to improve on them next time around. All right, let's go. All right, welcome to the first case. In this one, we're looking at 2 lateral foot x-rays. Okay, so lateral foot x-rays. And I just wanted to have both of them here and critique them and have them as comparison. The first thing you'll notice is that one is a little bit more flat. So this is what you'll expect from someone who's a little bit more flat-footed. And this one has a little bit more of a notch. Okay, so flat-footed versus someone with a bit more of a notch. And I'll be talking about the critique together as we go through the criteria. So the first one is P for positioning. Okay, in terms of positioning, is done quite well. Generally, you want the metatarsals to be overlapped like this quite nicely. We see the cuneiform bones over here. We see the cuboid bone and the navicular at the bottom, and then the talus over here, and of course the calcaneum. Then on top we have the tibia and the fibula. That's kind of what we see on a foot x-ray. I'm just going to get rid of those. But in terms of positioning, again, the metatarsals are relatively overlapped. That's quite well. The toes are obviously going to be overlapped, so that's not the focus of this one. Generally, we want to see the medial and lateral condyles of the talus, so we can see through that talus and tibia joint quite nicely. If it is rotated externally and or internally, you generally see the condyles kind of like this, okay, or the other way around, or if it's not angled correctly, then you might see it something like that. Okay, but generally that's within normal limits. So that's the positioning of the top ones quite well. What on the bottom you'll notice is that this is the first metatarsal, and all the other metatarsals are kind of out of the way, almost in like an oblique position. And this generally happens when you have the foot sort of over rotated more than normal. Okay, so this is almost like a flat lateral standard, and that one is an over rotated lateral. Okay, that's why you get this kind of look. In fact, there is a view what we call the over rotated lateral foot, where if we have pathology in the 5th metatarsal, for like, you know, if the patient has slips their foot or for whatever reason has a fracture there, that view really nicely demonstrates fractures in this area. Okay, I don't think specifically that was this view. Maybe it was. It doesn't seem like it will be rotated enough for that, because generally you have openings in these areas if that was the case, but that's why it looks different in terms of positioning. And by the way, this arrow is just showing an accessory bone that usually is not available in most patients that I've seen, but it's not really a fracture here as far as I understand it. Okay, so the positioning's done. Let's move on to the next one of area. Is the area covered adequately? For both of them, yes, very much. You got the toes of the front, the few millimeters or centimeters off the back of the heel. The top one, it looks like it's cutting off the skin border a bit, so that's cutting it a bit short. I will be careful of that. Not worth repeating. But same thing on the bottom one. You see the toes in the front, heel at the back, bottom, and almost a little bit of the ankle. Obviously, you see the ankle joint, but not so much of the tibia and fibula. Not the focus of a foot x-ray, but if it was, you would extend it out a little bit more. But anyway, in terms of area, it's quite nice. Collimation, again, for both of them, it goes similar to the area. Collimation is quite nice. The only complaint I would have is of the bottom over there. Exposure. Exposure, again, what are we looking at for exposure? The contrast levels and the noise levels. Contrast levels for both of them seem to be quite good. You can see the bone texture over here in both of them. I would say maybe the bottom one is a little bit more post-processed compared to the top one. In terms of noise level, I'd say the top one has a little bit more noise, particularly in these areas, but nothing to be to have to repeat. Okay, so both exposures are quite good. I wouldn't repeat them. KVP and MAS are both quite adequate. If anything, I would change some things in post-processing, such as the amount of contrast, let's say, in the bottom one. Exposure's done. Marker, okay, so I think this DX again from previous videos is referring to a right marker. So if that was the case, that is correct. The right marker would be put in that empty space over here. So think of the foot, if it's turned right, it'll look like it's to our left. That's how we imagine the patient's foot is literally turned right in front of you, and that's what it would look like. Okay, and obviously that's the other marker. It's translating to right, so the marker I am happy with. Aesthetics for both of them is quite nice. Again, ideally you would have the foot probably in this flat position, but if there's another reason to get an over rotated, then that would also be adequate as well. It's not that it's wrong to do that, it just depends on what you're looking for. Okay? So aesthetics also quite nice. And again, the other thing with aesthetics was the any artifacts that we see. I don't see any artifacts in this particular x-ray, and so I'm fine with that. Lastly, N for name. Now it looks like if you look closely, there's a bit of a black box over here. So that probably was where the details of the name were. And it was just anonymized for anonymous reasons. Same thing for the bottom one. This is obviously a different patient, but the name, again, is a freebie, and that's all good. Now, in terms of pathology and everything, there's no pathology. The only thing would be the arrow over here, which we said is an accessory bone. So happy with that? Let's move on to the next case. All right, so the second case, it looks like we're looking at a DP, dorsipalmar. It's not an AP, because the foot, you're looking at the back of the foot and the palm of or the base of the foot. So it's a dorsipalmar, DP, or a PA, okay, as we say it. And looks like part of an oblique. Okay, so let's go through the criteria and see what we think of this x-ray. So first one, P for positioning, excellent positioning for the DP. And generally what you'll notice is that for a DP, you don't do a straight tube, you do a bit of this is how the foot will be positioned. You do a bit of an angle to up, cephalic angle, and that's to make sure the metatarsals are perpendicular to the x-ray beam so they don't look foreshortened. So you can look at the proper length of the metatarsals quite nicely, and it looks like you can see the full length of them. That doesn't look like they've been shortened. Anyway, so the position of that and the x-ray tube seem to be quite well. Even for this one, generally going from a DP or a PA to the oblique, you see a little bit more of these area joint spaces and a widening of the fifth metatarsal, or the base of the fifth metatarsal in particular, on the oblique. And that's why it's really good for identifying fractures in that area. So positioning, I'm happy with that. Doesn't seem to be oblique too much, seems to be quite nice. Again, I'd like to look at the metatarsals and the position of them, comparing it both side to side. Okay, positioning done. Let's move on to the next one of area. Is the area covered? Now in this particular, the one on the left, it's definitely covered. You got the toes on the side, you got basically the talus, and you can't really see the heel in this one anyway, so that's all you would need. And side to side is quite nice. The oblique, on the other hand, you see the top, you see the side to side. However, it's just cutting it very short. Now, I would probably do this if I did the first one as the full foot and I realized the pain really is not in the back of the foot, it's really in the front of the foot. So just to save some dose, I cut the base and only focus on the top. That's perfectly fine. But if we're going by standard foot x-rays, then it's definitely not covering the base of the feet that you would hopefully want to see, almost like an oblique view of the calcaneum. Okay, so I'm going to put that's done, but could be improved, I guess, depending on the criteria that we're looking at. Collimation, again, both is very good, very tight towards the top and the sides for both of them, and we're just going to assume that the cutting of the base or the oblique is what they wanted to do. Okay. Exposure for both is actually quite nice. It's a little bit bright, and I think that is just a post-processing thing, because you can see the bone texture quite nicely. By the way, these are called sesamoid bones. It's just accessory bones beneath the first big toe, and they are here as well. Okay, everyone usually has those. Anyway, I was talking about the exposure. Exposure is quite nice. Bone texture is there. The contrast is there. It just looks like the brightness could be brought down. Okay, and so that would basically fix both of them. So happy with the exposure. It's obviously a little grainy towards here. That's because it's going through a lot more dense of an anatomy in that area. Not the focus of the foot x-ray, obviously. So even if it's grainy here, it's fine because the focus is, here to here, essentially. Okay. And so exposure is good, happy with that. Marker, again, so this was the right foot, and DX is referring to the right. So I'm just going to put right here. So that's a really good position for it to be in. It's the only area where it's just forcefully empty. So I like to put it in that area as well. And similar to the oblique, the right marker is in place. Happy with that. Aesthetics, nothing wrong with the aesthetics apart from the brightness that I mentioned and cutting off the bottom over here. So aesthetics of the image is quite nice. No artifacts that I can see here as well, so that's all good. The only thing you might want, if you want to be nitpicky, you can say that this little white line over here, that's I believe called the silver lining, which is showing you the actual collimation of the x-ray that was done. So nothing of concern. I'll say the aesthetics is really nicely done. And N for name, there's no name or ID on this particular x-ray for anonymous reasons. In terms of pathology, I don't really see any pathology in this particular case. It doesn't seem to be any fractures that I can see. I'm just having another look through. A little bit of osteophyte formation, a little bone spur here, which may be early signs of arthritis, but that's really about it. So happy with that. Let's move on to the next case. All right, so here now we have the left foot. Looks like a portion of the DP and some kind of oblique lateral. It looks like an oblique, extended oblique. Anyway, let's go through the positioning and see what we see. Okay, so positioning, this one is quite good. We'll talk about what it's cut off. Everything looks like to be an AP positioning quite well. Looks like it would have, the full length of the metatarsals are there. However, the positioning of this oblique one seems to be either too obliqued, because you can now start to see almost a little bit too much gap, and just the overlapping of the toes a little bit too much. This probably would have been fine if they put some tape on the big toe and pushed it out a little bit so it wasn't overlapping with the second toe. But other than that, positioning could be improved in that regard. But half of the x-ray we can't see, so I'd say that's good, but could be improved. Area, definitely you're cutting off this side, you're cutting off the base of the foot. Again, similar for the oblique, you're cutting off the base on the sides. What I would hazard to guess is that this was a big toe x-ray, okay, and potentially query and that's all they were interested in. So they kind of got the big toe and some of the adjacent toes to see what it looks like in comparison. But then again, if it was the big toe, it's overlapping, so that's not really ideal. You got the big toe here, got the second toe here, so not ideal what's going on. Covered, but could be improved. In terms of collimation, top to bottom, top is good, side is good. Again, top and sides are good. If that was the only area of concern, I'd say the collimation is quite nice. I wouldn't really be worried about this being excessive or not enough, but it depends what they're looking for. So if I'm just worried about this being a big toe x-ray, collimation is good. If it's a full foot x-ray, terrible. You need to cut something off and not ideal. So done, could be improved. E for exposure. Exposure, MAS is probably a little bit low just because the bone texture is getting a little grainy and you can't see any detail here. KVP is probably quite low as well, and there's not enough penetration to go through. So exposure in general could be improved. It also could be just, post-processing thing, because the background just looks quite light gray, which is not usually what you're meant to see if the window width and level is actually quite adequate. And window width and level is just the brightness controls and contrast controls. Other than that, exposure could be increased, I would say, a little bit. So good, but it could be improved. Marker, this is the left foot, and they do have a left marker over here, even though it's sort of turned sideways. So ideally, left marker in that particular area, left marker here, anywhere that there's some space, but the marker's there, just orientation could be improved. Aesthetics of this image is not really good. One of the things is that at the border of the x-rays, this area should just be black, not white, so it hurts the eyes, right? That's one thing that issues with, I guess, with post-processing collimation. Exposure isn't that ideal. It's not really clear what area of the anatomy they're looking at, if it's the big toe or second toe or just sort of the upper foot area. I guess that's good, but in the oblique it's not really ideal. So not really good aesthetics. It definitely could be improved. And lastly, N for name, there's no name or identification seen for anonymous purposes. Now, in terms of pathology, I don't really see any pathology in this particular case. Again, maybe a small, osteophyte here. There's no fracture that I can see, at least to my eyes. So seems to be okay. And so hopefully that made sense. Let's move on to the next one. All right, so the fourth case, this one's a bit of an interesting one. I think this was upside down. I had to just flip it. That's why this looks weird, and the 4 centimeters is upside down. But anyway, looks like we're looking at a right foot. Okay, so right foot x-ray. Okay. We have the DP and an attempt at the lateral. So let's go through the positioning. The DP is quite good, it's positioned quite nicely. I can see everything in AP profile, there's no rotation or tilt as seen. However, the lateral definitely could be improved, right? First of all, it's in an okay position, but there's a lot cut off. This isn't ideally, it looks like it's a little over rotated compared to what it would have been normally. Again, still within normal limits, but not really ideal. Okay, so positioning, okay. The lateral in particular could be improved. Area, is the area covered? Top to bottom is covered, side to side maybe a little bit I guess, too much. The base is okay. We're not really interested in anything below that anyway. For the lateral, we got the toes, we got the bottom of the foot, but we're sort of cutting off the heel. So this would usually be a no-go. You need to include that in the foot x-ray, unless you know that there's something definitely in the front of the foot and nothing at the back. Which, if that was the case, then, you know, why are we including all of this? Okay, so food for thought. Other than that, we have the top of the foot covered, but, you know, the talus and sort of the tibia and fibula is sort of half covered. Not really ideal. So whatever they're looking for, it seems to be okay, but definitely the area could be improved. And which goes also for the collimation. You know, top and side to side is okay, could be improved slightly. And for the lateral, definitely all this is not really necessary. If that's not included in the x-ray, just cut that all out and instead include it back here. Okay, so this would have been a much better collimation in that regard. Okay. Exposure. So the first thing you probably noticed, apart from the poor positioning, is how white the x-ray looks. So it doesn't look like it's been penetrated enough. I'd say the KVP could be improved, and also probably a little bit the MAS, just so you can see a little bit more detail throughout. There's a bit of graininess over this area. Maybe they use the same, you know, KVP MAS for both of them, which, you know, for the lateral, you typically need to up it a little bit because you're going through more thickness and density. So in general, it looks like it's a little underexposed, and I would increase both exposure factors. Marker, so that's just seems to be wrong, because if this is a right foot, the right foot mark needs to be there. This also looks like, you know, if it was rotated in the correct position, it would also have been the right foot looking. So marker is just incorrect, and that needs to be improved, even though it was a digital marker. So not sure what's going on there. Aesthetics definitely could be improved in many ways. We talked about the exposure. We talked about, you know, cutting things off, being aligned a little bit better. Also, in terms of artifact, you see that squiggly line over here. This just sees probably the patient's pants wasn't rolled up enough, which does affect image quality, particularly in the areas that it does. It may mimic some kind of fracture if you're not careful with it. So that's something to take note of. Aesthetics done, could be improved. And lastly, N for name. There's no name or identification seen for anonymous reasons. No pathology that I can see in this particular case. We're obviously looking at a pediatric x-ray with all these growth plates throughout. So these are not fractures, these are just a young patient. Even in this area, there doesn't seem to be anything. Again, that's also a growth plate in the heel. These are all growth plates. So not much that I can see in terms of pathology. At least to my eyes at this stage. So that was that. Let's move on to the last case. Okay, so we just have a one x-ray in this particular case. So it looks like a DP foot x-ray. Okay, so positioning is quite well. In my eyes, it looks like a little short here. So I'm not sure, maybe they angled enough or not. Hopefully they did. That's the only concern I would have in terms of its positioning. You are sort of positioning done. Area, we are covering everything that we need. We have all of the toes, you have the sides, and we have the back of the foot all the way to the heel as well. So happy in terms of the area that's covered, but in terms of collimation, definitely could be improved. Got a lot on the top, a lot on the sides, okay, and the back is okay. I think if it was just, you know, collimated like this, and maybe rotated, you know, left a little bit, externally rotated, it would have been aligned a lot nicer, and that would have improved the image quality in that sense. Okay, so collimation good, done, could be improved. Exposure looks a little underexposed, very contrasty, a lot of blacks and a lot of bright whites. So increasing the KVP, looks like the MAS is quite nice. There's not as much graininess that I can see. The bone texture is quite good. So a little underexposed in that sense. Probably also post-processing would have helped in this particular sense as well. Okay, so exposure done. Marker, that's not correct. It should be a left marker in this particular case, because this is the left foot that we're looking at. So that's the wrong marker. Done, but could be improved. Aesthetics, not the best aesthetics. Okay. X-ray could have been improved in terms of its exposure, slight rotation, definitely in terms of collimation. All of that would have made this a little bit more nicer. Again, compared to other X-rays, maybe it's just the patient's length of their metatarsals, but it looks a little short compared to normal. And if that is the case, it's probably because it didn't angle up. hard to tell just by looking at the x-ray, but that's what it looks like. So aesthetics done, could be improved. And N for name, there's no name or identification seen for anonymous reasons. Pathology, I don't see much pathology apart from just looking at the toes. It looks like early signs of arthritis. There's not much joint space narrowing apart from maybe in some of these areas over here, the Liz Frank area. So maybe early OA, but that's really all I see on this. No fractures that I can see. So hopefully that was helpful. All right, that's it for this one. If you found it useful, please give it a like. I really appreciate it. Now click here to watch my other video on shoulder critiques and over here to watch the full playlist of all the critiques. See you there. Stay curious.